All right, everyone, I think we'll go ahead and get started. Feel free to continue to get breakfast and coffee and all the treats in the back. But I think this is this the last discipline group for, can you hear me now? Okay. Thank you. This session is called Off the Beaten Path, a non-traditional approach to optimizing pharmacy care. And we have 4 great speakers for you today. Just a disclaimer from every presentation. Adrian, my partner, and I do not have anything to disclose this morning either. Our objectives for today are fourfold. We're going to have 4 great speakers. First one is going to evaluate health literacy, its impact on CF, and tools for effective educational materials for patients and caregivers. We're going to assess scenarios in which deprescribing medications related to CF care should be considered. We're going to discuss the evidence for utilization of probiotics and other supplements in CF, and we're going to learn strategies to advocate for patients struggling with access to medications due to alternative funding programs. Here are our presenters today. I'll let each of them kind of introduce their titles as they come up. And our first presenter is going to be Amber Elliott. She is a clinical pharmacy specialist at the University of Texas Health Sciences Center of San Antonio Pediatric CF Center. She has worked in CF for more than 5 years and has had the opportunity to train at a couple of accredited CF centers during her pharmacy residency. When she joined her current CF center 4 years ago, she was the first clinical pharmacist on both the pediatric and adult teams. With the center's growth, she has been able to focus solely on the pediatric population, fulfilling her long-standing career goal since her pharmacy school days. Okay. All right.
All right. All right. Thank you for that introduction. So I'm very excited to talk to you all this morning about health literacy. It's something that is really important to me, and I think it's really important to all of us. As one of my favorite goals is advocating for my patients and educating them. So we're just going to talk about how health literacy impacts how it impacts people with CF, and how can we improve health literacy for our patients and families. I have no disclosures related to this presentation. So just a brief outline. We'll first start off by defining health literacy and then discussing the risks and impacts of health literacy. And then we'll kind of look into what the literature says in regards to health literacy in people with CF. And then we'll talk about some strategies for improving health literacy and how to create those health literacy friendly resources to optimize pharmacy care. So health literacy is traditionally defined as the degree to which people obtain, process, and understand basic health information and services in order to make appropriate health decisions. However, this definition was recently expanded by the U.S. Department of Health and Human Services in Healthy People 2030. And this was the first time that the Healthy People initiative actually included health literacy in one of the overarching goals of their healthcare objectives. And this updated definition divides it into 2 different things. So there is the personal health literacy, which describes the individual's ability to find, use, understand, and then use that information to be able to make informed health-related decisions, both for themselves and maybe for others, like their family members, as well as this organizational health literacy. And so this really defines that organizations are also responsible for enabling individuals to find, understand, and then use that information and resources to be able to make informed health-related decisions and actions. And so the concept of health literacy can be further divided into 3 key themes. So the first is going to be obviously knowledge. So whether that's understanding your basic health information. So what's your disease? What are the medications that are needed to treat your disease? As well as maybe some public health understanding. how to navigate their healthcare system as well. And then that second one is being able to process and use that information in relation to the healthcare system. And finally, it's the ability for patients to use that knowledge and that information skill set that they received to effectively then manage their health. So that really kind of involves some interpersonal skills, but also is involved collaboration with our healthcare providers like us. And that's kind of defined as more as like shared decision making. So research actually shows that nearly 9 out of 10 adults have difficulty using the everyday health information that's routinely available, both in our healthcare facilities, our retail settings, in the media, and just the general community. And so everyone, no matter how educated you are, actually is at risk for misunderstanding health information. And this is especially true when we're thinking about like these very emotionally charged situations. And so in almost all cases, healthcare providers, they try and they believe, I mean, we all believe that we're going to be communicating these things accurately and in an understandable way. And honestly, patients believe that they also understand. And sometimes they're embarrassed to ask questions that maybe would, help them to confirm whether they understand or not. And so when we think about like these discussions that we have, they're just always very difficult. When you're talking about risks of things, it's emotionally charged. It's a challenge for both patients and providers to have these difficult conversations. And as we all know in our world today, with everything that's available online, the evidence-based information versus, maybe some gimmicks and things out there that people are learning is making it increasingly difficult. So the main thing that I like to just kind of remember is that we cannot blame the individual for not understanding information that has not been made clear. And so we really need to continue to work on improving that. So what are some risk factors? Well, like I said, everyone's at risk, but there are people that are at a higher risk, and those are people that maybe belong to our minority ethnic groups, or they don't speak English as their first language. Definitely our lower socioeconomic status or lower educational attainment has been associated with some low health literacy. People that are unemployed or low income earners, as well as our elderly patients, are often at risk. And the impacts of health literacy can actually be felt across the entire health system. So typically that looks like people that are using the ER or the emergency care system at a higher frequency, those that, and they don't use preventative care services because they don't understand them. This leads to more hospitalizations and higher healthcare costs. At the individual level, people aren't able to participate in shared decision making because they have to have a baseline level of health literacy, and they have a poor health status and a higher morbidity and mortality. So when it comes to medication adherence, the impacts of health literacy have been less clear. So Hybert and colleagues actually completed the systematic review looking at studies evaluating the influence of health literacy on medication adherence in people with chronic diseases. And they found that a majority of the studies actually found this positive relationship. So those that have higher health literacy have better medication adherence. But then there still was a third of those studies that actually suggested that there was either a negative or no relationship at all between health literacy and medication adherence. And so this inconsistent relationship between health literacy and medication adherence, it's not, unique. Like, it makes sense because medication adherence is impacted by so many different things, especially like a patient's belief or their perceived health status, or their just general self-efficacy and wanting to participate in care. But it still plays a substantial role when we think about addressing non-adherence with our patients. So we definitely need to consider targeting health literacy. What about health literacy in people with CF? So in Ireland, there was actually a study by Jackson and colleagues that looked at how does health literacy impact health outcomes in our adolescent and adult patients? And so they compared health literacy also with people of a matched cohort in the general population. And surprisingly, but maybe not surprisingly, 80% of participants with CF actually were considered to have sufficient health literacy. So that's most likely because there's so many interactions between patients with CF and the healthcare system. The risk factor that they actually found most commonly associated with lower health or limited health literacy in those CF patients was actually educational attainment. But when it came to looking at the impacts, so those with better health literacy had a better quality of life when it came to their CFQ-R scores. And then those that had limited health literacy actually experienced more clinic visits or outpatient visits. They had more prescribed oral antibiotics, and they had a longer duration of their hospitalization stays. So when we think about it, when we compare our patients or people with CF to the general public, their health literacy was significantly higher. But at the same time, that does not remove that risk of them actually still having some limited health literacy and really the negative outcomes that are associated with that in terms of on their health outcomes and their quality of life. And then when we look more at medication adherence, we have a couple studies out of Canada that looked at medication adherence in adult patients with CF. And in the first study out of Vancouver, they actually found that 3/4 of these patients could remember within 5% their last FEV1. That's really impressive, in my opinion. And they actually knew all the benefits of their medications, but still 50% of them were considered to be non-adherent. And so they defined adherence as people that were, it's self-reported as taking 80% of your medications over the past 3 months and 20% missing less than 20% of your medications in a general week. And so they, doesn't mean that, just because you understand or what your benefits are doesn't translate directly over to taking our medications all the time. But they actually did find a positive linear relationship between those that are prescribed, the number of prescribed medications, and then that self-reported in medication adherence as well. And then flipping over to this study out of Ottawa, they actually found that a majority of patients understood the recommendations, but they actually misunderstood the frequency. So they knew that they were prescribed a therapy, or they knew that, their provider wanted them to do their VEST, but they didn't understand exactly the instructions. And when it came down to adherence, actually the patients were very good at adhering to their own understanding of their treatment, but they did not adhere to what the healthcare providers were actually prescribing. And so that's just, again, a factor for us to remember that, it is really important that we make sure that we provide understandable information to our patients. So now that we have talked about what are the impacts of health literacy and what does health literacy look like in our people with CF, let's talk about some of the things that we can do. So just kind of like this big overarching goal as, healthcare providers, in order to address health literacy, we really need to build relationships with our patients. We need to develop guidance, and we need to be advocates for changing policies. And so I'm going to focus a little bit more on what changes we could possibly make within the healthcare system to improve health literacy, as well as developing and distributing this actionable and accurate information. So the first off is going to be this healthcare literate model. And so, this actually is a model that uses our current like chronic care model and transitions it and weaves in health literacy within all the avenues. And so what it calls for is that we approach all of our patients with this assumption that they are at risk of not understanding their healthcare condition and how to deal with them. And subsequently, we need to work with them to confirm and ensure that a patient does understand. So asking those, feedback questions and having our patients repeat back to us the things to ensure that they understood what we were saying to them. And then for the healthcare organization level, it just really encourages healthcare organizations to implement different aspects that can, be utilized to help encourage shared decision making throughout the entire process. So next, kind of looking at what we can do when we're developing. So this actually came from a really great resource that I found on the CFF resource library from the CFF Education Committee. And it talks about developing or adapting educational resources in a health literacy friendly manner. And so it has 6 core principles. So first off, we want to make sure that we have a clear main purpose stated. So we want our title and initial information to be specific to the main points, and we want to avoid having these like creative. So if you're thinking like for ototoxic medications, the fragile balance of sound and survival, that means nothing to anybody. But if you were saying, hearing the warning, ototoxic medications for monitoring for CF patients, like that is very clear as to what we're going to be talking about in that resource. We want to avoid unnecessary information and focus really only on the things that you need to know. So if you are talking about tobramycin because it's ototoxic, even though we know that it's being used for Pseudomonas, we don't need to include stuff about the negative health outcomes of Pseudomonas within that handout, just focusing on the things that we're really trying to convey. Making sure that we're using plain language. And so that's just really at that baseline, plain language is easier for understanding, and so it's less likely to be misinterpreted. And then there's, we want to make sure that we chunk information. So we want to make smaller chunks, breaking down these longer sentences into smaller sentences. When you look at a piece of paper and it's lots and lots of sentences for someone who has difficulties with reading, that's just becoming overwhelming, and that's not a useful resource for them. We can definitely use visual cues and aids, so highlighting information that's important, but remembering that over-highlighting can definitely mislead someone and they may not be able to follow that. And, of course, using pictures. So if we're thinking back to our ototoxic medication handout, having a picture of an ear. So that's very helpful for someone to know, oh, this is about my hearing. And finally, when we are thinking about numbers, so we talk a lot about numbers, we talk about side effects. 4% of patients experience ototoxicity. What does that mean to anybody? So they really recommend, using 4 out of 100 rather than, 4%, and then also saying that's a low risk if that indeed is like a low risk. So just explaining that within it and not just having that number there. All right, so maybe you created a resource or you found a resource and you want to make sure that you're evaluating it. So there's definitely some things that we can use to evaluate whether our resource is useful. And so first off is this health education materials assessment tool. And it's a 7 to 8 item questionnaire. That's a yes or no. And basically, if you answer yes to everything, then you're easy to read. And so that is one place to definitely start when you're evaluating your resource. The next is definitely getting feedback. So handing it to your patients, to their parents, and saying, look through this. What do you think? What questions do you have after looking through this? What did we miss? What did you not understand? And then, of course, there's readability formulas. So there's the Flesch-Kincaid grade level, and making sure that it's below or at a 8th grade level. And then we can use alternatives. So maybe they can't read at all. So using our visual like videos or audio like podcast things to help. And then finally, we can utilize some literacy guides. So, not surprising, there's not a lot of research on assessing the health literacy of the educational materials that are out there. But there was this actually really interesting study that looked at developing educational materials for children with cystic fibrosis out of Ireland. And they talked about how they developed these. And so I thought it was very good information to share. So they kind of tried to target 3 different areas. So one being how to collect a good respiratory specimen, how to clean and sterilize our nebulizer supplies, and then what is pancreatic enzyme replacement, or PERT, for those that suffer from pancreatic insufficiency. And so they collaborated with both the children and the parents, as well as some animators and educators within their system. And they created both coloring books and storybooks, like this one here on the slide, for engaging their children with CF to teach them, as well as creating a video about each of those 3 topics. And so what they did for assessment of understanding for the PERT is they asked the parents before and after viewing this information what they felt like their children's understanding. And prior to viewing it, 50% of the parents felt that they either had no, limited, or moderate understanding. And then afterwards, they felt like all of the children actually had good or very good understanding of the information. And so I think, one, I might be a little partial since I do work with our pediatric patients, but I also think it's really important to engage our patients from the beginning. And so if you can create a coloring book, something to help them, to engage them, this allows them to be a successful transition into adults and adolescents. And so they also kind of gave some more basic information to consider when developing these educational materials for children with cystic fibrosis. They're very similar. I will say one of the things that I liked that they, maybe I hadn't mentioned before, was that they actually also want you to use these materials to promote asking questions, and within that they want you to make sure that you explain who to ask. So I thought that was also really important. And then I just wanted to share a couple of resources that I actually found while creating this presentation, and one of those is a cystic fibrosis action plan. And I'm not sure if anybody has ever seen this, because I have never seen this. It is actually very, very similar to our asthma action plan, which I see all the time. But it actually has these images and these pictures that we can utilize that show different symptoms, and allows for patients to understand what their symptoms look like and what they need to do. So, do they need to increase their treatments at home? Do they need to contact their CF team? But also within this, it allows you to individualize their medication plan. And so you can go in and select, and I actually played around with it. It's very easy to use. You can say, how many enzymes should you take with your snacks and with your meals? And it talks about pictures of stools so they can kind of get an idea of what constipation looks like. So this is definitely a useful tool that's out there. So I just wanted to share it with everyone. And then I kind of wanted to just share a couple things that we created as our CF Center. So something that we did for a QI project that we had a couple years ago about bone health and vitamin D. And so we put this guide to vitamin D in the rooms. We laminated it, and I've had so many patients ask questions, but like you see, we made sure that was readable, that 8th grade level. We had pictures, and then we had this exercise that shows kind of like the activities that people can do to build their bones. So just some different things to think about when we're creating resources for our patients. So in summary, everyone or anyone is at risk for health literacy issues. And for people with cystic fibrosis, a low health literacy may be associated with some poor medication adherence, but it definitely is tied to poor health outcomes. And so that makes it a really important thing for us to consider. Health literacy is a modifiable risk factor for morbidity and mortality. So, we can work together. So we need to continue to strive in order to, improve quality of care for our patients. So what can we do? Just as a reminder, we can work with our healthcare organizations. We could implement this health literate care model. We can collaborate with educators, making sure that within education systems, health information is shared. So, doing some different events within our community. And then we can complete more training, working on our communication skills. And finally, we can develop and share those educational materials that are understandable and culturally competent. And with that, I'll take any questions.
Can y'all hear me? No.
Hey.
Didn't turn green.
Okay. Oh, I think it's on.
Okay, is it on now? Okay, can y'all hear me? Okay, perfect. Okay, so I was actually going to ask the same question. Where did you find the CF action plan?
So I actually found it in a paper that I found. I'll try to see if I can add it because I think I can link a resource, and so I'll add it to the resources linked to this presentation on the NACFC app, or I can put it on the listserv for everybody, I guess, too. So, but yeah, it was just an article that I found, and I had to go in, but it's through CFRIs, so it should be around. I just never had heard of it. I was gonna see if I can get it implemented into Epic in our health system too.
That was actually the next question. Is this something that you plan to put into Epic, or is it a standalone resource?
It's not an Epic yet, but I was gonna send it to our within our internal system, and I can share if I am successful and give hints to anybody who's interested in also implementing it because they have the asthma action plan. So,
Any other questions? Feel free to go up to the mic if you want to. All right. Thank you.
thank you.
Hi guys. Okay, our next presenter is Alex Carberry. She's a pharmacist at Helen DeVoe Children's Hospital CF Care Center. She has been interested in cystic fibrosis since attending the University of Oklahoma College of Pharmacy, and after 6 years of splitting her time between inpatient and CF, she is thrilled to have recently become fully embedded in the CF clinic.
I know, me too. Good morning, everyone. Okay. So this morning we'll be talking about deprescribing medications and focusing on proton pump inhibitors. I have nothing to disclose. I don't know if you guys saw that. I did not see it. First, we'll start by describing acid-reducing therapy use in cystic fibrosis, talk about the risks and benefits of using proton pump inhibitors in our patients, and then identify candidates for deprescribing and formulate and how to deprescribe. So as I go through the slides, I'll be sharing results from a survey that was conducted the last couple of months. Many of you probably, hopefully, responded. The survey asked about acid-reducing therapy prescribing practices and was distributed throughout a couple of different CFF listservs and the PED lung discussion group. There were 80 responses. I thought it was kind of fun that there were some responses from India, Iceland, and England. And most of them were pharmacists and pulmonary providers. Most respondents also are working in a pediatric setting. So acid-reducing therapy is often used for gastroesophageal reflux disease, or GERD, or pancreatic enzyme replacement therapy, PERT optimization. Despite being commonly prescribed, there's limited data and guidance in CF and increasing concerns for potential complications with long-term proton pump inhibitor use. According to the survey results, 65% of respondents are using acid-reducing therapy for both GERD and PERT optimization, 33% for GERD only, and 2% just for PERT optimization. The most prescribed acid-reducing therapies are PPIs and histamine 2 receptor blockers, or H2 blockers. These graphs are from the CFF 2024 Patient Registry Data Report, and the graph on the right shows percentage of individuals using PPIs or H2 blockers by age. H2 blockers are shown in red and are prescribed more often in children and then kind of tapers down, whereas PPIs, shown in blue, increase into adulthood. In terms of the specific medications that we are reporting as being prescribed, there's a bunch of different PPIs that were being reported. Most often was omeprazole, and then famotidine was the only H2 blocker that people reported using. These medications are being prescribed by a variety of different providers, both in and outside of CF clinic. Just a real quick review, proton pump inhibitors irreversibly bind to acid-secreting proton pumps to decrease acid secretion and increase pH. But as I've kind of mentioned, prolonged PPI use is associated with higher costs, increased medication burden, adverse events, and potential complications. This table shows some of the risks associated with long-term PPI use. And as you can see, there's potential impact on a lot of different areas, some of which we might be a little more concerned about with our patients with CF, like the risk associated with lung function, vitamin deficiencies, and fractures. Highlighted in this orange box are some of the pulmonary risks that were identified in studies conducted specifically with people with CF, in people with CF. It is important to note that most of the studies on adverse events in PPIs are observational and may have potential confounding bias. Before we get into deprescribing, I want to quickly review how we use PPIs in CF care, starting with their role in GERD. The Montreal definition of GERD is a condition which develops when the reflux of stomach contents causes troublesome symptoms and/or complications. The prevalence of GERD is higher in people with CF, and in the U.S. in general, about 20% of people have GERD. If you look at this graph, again from the CFF 2024 Patient Registry Data Report, you can see that it starts at 20% around infancy and then creeps up as someone ages, and for most of adulthood, it kind of goes between 40% to almost 60%, which is 2 to 3 times the prevalence of the general U.S. prevalence. GERD and CF have a complicated and bidirectional relationship. The prevalence of reflux and acid can negatively impact the respiratory system and cause cough and exacerbations. Using medications like PPIs, they don't reduce the reflux. They instead shift the ratio from acidic to non-acidic reflux, which also impacts the lung. Powles and colleagues detected bile in the sputum of over half of adults with CF, which was associated with airway inflammation and a decrease in lung function. There are many proposed mechanisms for GERD and CF. However, the literature is a little bit inconsistent. Some of those proposed mechanisms include rate of gastric emptying, which is shown to be variable in people with CF, low gastric pH, decreased lower esophageal sphincter tone, impaired motility, and diet and lifestyle. So how do we treat GERD? Well, first we usually will start with diet and lifestyle changes, which may or may not be feasible for our patients. We all know that we closely monitor nutritional status in people with CF, and weight loss or restricting fatty foods isn't always appropriate. Similarly, avoiding meals at bedtime might not work for someone that takes their CFTR modulator at night and needs some fatty food or snack. On the other hand, having small, frequent meals may increase energy intake and help people to reach their nutritional goals. After diet and lifestyle changes, we have medications and then anti-reflux surgery. There are multiple drug classes that we use to treat GERD. We have antacids, which are often used on an as-needed basis, H2 blockers, and then finally proton pump inhibitors, which offer superior symptom relief and healing in GERD compared to the other medication classes. Next, let's switch gears and talk about PERT optimization. As many of us know, pancreatic insufficient patients require enzyme therapy to help with the absorption of fat, protein, and carbohydrates. Unfortunately, gastric acidity can lead to suboptimal PERT responses by preventing or slowing down the dissolution of enteric-coated enzymes. Theoretically, an acid-reducing therapy should decrease duodenal acidity and improve dissolution of PERT, so we sometimes add it when we have patients with gastrointestinal symptoms, they're having insufficient weight gain, and especially when they are at max out on their PERT dose. Adding acid-reducing therapy to optimize PERT is recommended in multiple guidelines, but the data is limited. Phillips and colleagues published a small, randomized, double-blinded, placebo-controlled trial studying fat malabsorption in people with CF that were on PERT and both on and off PPIs. They found no significant difference in fat malabsorption. A 2021 Cochrane review found conflicting data, with some studies showing an improvement in fat absorption, but they were unable to conclude whether or not acid-reducing therapy improves nutritional status, lung function, quality of life, or survival. Definitely more randomized controlled trials are needed to determine if acid-reducing therapy is useful in optimizing PERT. We've covered that we use acid-reducing therapies to treat GERD and help with PERT optimization. However, long-term use of PPIs may put our patients at increased risk. So it's important to consider whether therapy is appropriate and if the benefit outweighs harm. What is deprescribing? It's the planned and supervised process of dose reduction or stopping a medication that might be causing harm or might no longer be providing a benefit. The goal of deprescribing is to reduce medication burden and harm while maintaining or improving quality of life. An encouraging finding is from Odenthal and colleagues, who found that 95% of long-term PPI users were able to either discontinue or reduce their PPI use. So how do we start? The first step is regularly reviewing indications. Bustios and colleagues found that 85% of patients either on a PPI or an H2 blocker did not have an indication, which leads us to understand that there's a lot of unnecessary drug exposure. When starting to deprescribe and starting the discussion of deprescribing, it's important to collaborate with our patients through a shared decision-making model. And to make it even easier to start, we now have a specific CF deprescribing PPI algorithm. Omacine and colleagues published this algorithm last year, specifically for our patients with cystic fibrosis. The decision to deprescribe is based on indication and effectiveness. If nutritional status is adequate, reflux symptoms are controlled, or length of therapy is 12 weeks or greater, it's recommended to deprescribe. If that criteria is not met, perhaps nutritional status is still a concern, or the patient isn't on a highly effective modulator, GERD symptoms are present, and therapy has been less than 12 weeks, it may be appropriate to continue the PPI as long as there aren't recurrent acute pulmonary exacerbations or a history of C. diff or bone disease. Once we've identified an opportunity to deprescribe, there are various ways to do so. Due to variability in outcomes across studies, no single best method for stopping therapy has been identified, but many people start with the stepping down therapy. Usually that would be from high dose to low dose, maybe BID to once daily, every day to other day, something of that fashion. We also have on-demand medications that we can use for symptom control, or just abruptly discontinuing. When changing therapy, we should be providing education to our patients on what to expect and how to handle symptoms that might return. Proton pumps are generated about every 48 hours, and symptoms may return several days after a dose change. For patients that are on long-term therapy, there's concern for rebound acid hypersecretion. During PPI use, the increased gastric pH leads to high gastrin levels, which promote the proliferation of acid-producing cells. When therapy is stopped, there's an abrupt drop in pH, and symptoms may return. Physiological studies suggest it may take up to 6 months for these cell masses to regress. It's important to educate patients on this phenomenon and explain to them that the return of symptoms does not necessarily mean that they will have to be on continuous PPI therapy. Reviewing diet and lifestyle modifications and using on-demand therapy can help during this time. After we deprescribe, it's recommended to follow up at 4 weeks to assess symptom control, 12 weeks to assess symptom control and look at frequency of on-demand use. And some studies also recommend following up at 6 to 12 months, which especially makes sense for those patients that might be experiencing rebound acid hypersecretion. Okay, now we'll move into the survey results, starting with how we're reportedly starting therapy. 54% of respondents report a stepwise approach to starting these medications, with many starting with diet and lifestyle changes and then working up to PPIs. 33% not using a stepwise approach, and of course, therapy can be individualized and variable depending on prescribing practices, the patient, and the indication. We now know how important it is to review indications and understand why someone is on therapy. So what are we doing in the real world? 7% of respondents reported having a standardized process to reviewing acid-reducing therapy. 33% of respondents reported having some type of system, but nothing standardized. Some of those non-standardized reports were maybe just having chart reviews, a built-in template reminder in their note, or limiting prescription refills. And then 43% of respondents wish that they had a standardized system. When it comes to deprescribing, how are we deprescribing? 25% of respondents noted having some type of process in place. 19% of those had a standardized process. Some of the reported deprescribing processes that were standardized were an algorithm, or including GI to help with deprescribing if someone had been on therapy for a certain amount of time. We know that we're going to experience barriers when it comes to deprescribing. So perhaps someone has an unclear history, the patient doesn't know why something was started and they don't want to stop it. Maybe a provider did not start something and they're uncomfortable making changes that another provider started. Both patient and providers can be apprehensive or worried that respiratory or nutritional status will decline in stopping therapy. Providers may be uncertain of the guidelines for deprescribing. There might not be a workflow to help promote it. And lastly, just patient reluctance. Maybe they're worried about return of symptoms. In the survey, all of these barriers were echoed, but I also thought it was interesting that 11% of respondents reported not thinking about it or prioritizing it. Just to quote some of the responses, some people said they've been on them for a while, we just don't think about tapering off, clinic is really busy, or we just don't have a good opportunity to review patients to determine if they could be tapered. We can't talk about the CFGI track without acknowledging how CFTR modulators are impacting it. CFTR proteins are located throughout the epithelia of the GI system, and highly effective modulator therapy has been shown to improve intestinal function through reducing reflux symptoms and normalizing intestinal pH. We also know that early CFTR modulator therapy may improve or reverse exocrine pancreatic insufficiency, and we have case reports suggesting that in utero exposure to CFTR modulators may delay or prevent CF complications, as CFTR mRNA is highly expressed in the developing pancreas. However, as long as we're using PPIs for our patients, we have to keep deprescribing in mind. In summary, it's important to regularly review indications for PPIs to consider when deprescribing is appropriate and make sure that our patients aren't on unnecessary medications. Take into consideration the potential risks associated with long-term PPI therapy. We know that there are multiple ways to deprescribe and no single best method has been identified. And lastly, per this survey results, many centers would benefit from having a standardized approach to reviewing acid-reducing therapy and deprescribing PPIs. I hope that you're able to use some of the information we covered this morning to improve your program's use of PPIs and decrease medication burden to avoid unnecessary harm. Thanks.
I'll have Alex stay up here just for a little. Does anybody have any questions? Cool. Yeah.
Good morning. Not sure this is on. Oh, I hear it. Yep. It's on. Okay, great. I'm Catherine from University of Wisconsin, and welcome to being embedded into a CF clinic.
Thank you. It's
That's
the
awesome.
best.
So my thoughts are many. It's a great topic about deprescribing, especially in this, high, the modulator era now. I guess what I wanted to share is that as we move forward with having more and more pharmacists embedded in the clinics, I'd like us to consider discussions moving forward about, is it really once a year? I hear that, it's once a year to see patients. And I think that we might be missing all kinds of opportunity for this type of intervention and benefit for patients because things just kind of stay on the medication regimen, whether it's from the CF prescriber or another CF prescriber, particularly when patients are getting older and there's all kinds of other healthcare providers, seeing the patients. And so I would like to advocate for pharmacists to not just be boxed into a once a year visit with the patients. And just, I guess that's all I want to say.
Yeah, no, I think a lot of us also want to see our patients more than once a year. Correct me if I'm wrong, I believe that like registry recommends once a year or something like that, but I do know that depending on, like different centers have different pharmacist availability. So I see my patients at every visit, but centers that might not have as much FTE dedicated to pharmacy and CF might only be able to make that 1 year visit work. But I think with, what we know with like the change in our role and how we're now part of the team for the position paper, that will hopefully be changing. Yeah, thanks. We want to be there too.
Did you want to ask your question?
Oh, I actually submitted it.
Oh, perfect.
Perfect. Okay, we have 2 questions on the app. First one is, what things do you check in your follow-up after deprescribing besides just asking about symptoms? Or is it mainly symptom-based?
Mainly symptom-based. And then also depending on responses, sharing with the rest of the team members that might, if it was, depending on why they were prescribed, if it was for per optimization, then including our RDs. If GI started it, then connecting with him to see if there's anything else that he wants to dig into, but usually starting with just asking about symptoms. Yeah.
And then, did you see a link between PPI use and SIBO during your research?
I did not. I did not. I don't think I did. I looked at so many things, but I don't think I did. I was trying to only include things. I don't think so, but I'll double check. Okay, thanks. Appreciate that. Thank you.
Very relevant topic, I think, and we all struggle with this. So, Tara from Pediatric Children's Nebraska. This is something that we have struggled with quite a bit in some of our pediatric patients, and I'm sure then in adults that transition and never get addressed is an issue. Where I've had great success is with our younger patients. So since I've been integrated into the clinic, I'm very proud of the rates of our PPI prescriptions have declined significantly. But I do struggle a lot, and I'd love to hear your feedback or anyone else's in the room for patients that are in their teen years and I'm coming in to try to get them to wean off. And it's really sometimes quite difficult to find a wean and find a happy place. So we do a lot of dose reductions, but I'd say I'm probably about 40% of the time my patients aren't successful in actually weaning all the way off. And I'd love to hear other people's successes, even with optimization PERT. I don't know, our rates are not where I'd like that to be. So what have you done to find success?
Well, interestingly, when I started looking at this, I ran our numbers and we don't have as many as I thought of, as many patients as I thought that were on PPIs. So there haven't been like we haven't had to do it a ton in our clinic. But I do know that in the few instances I can think of, especially in older patients, we'll attempt to do some type of taper plan. Yeah. Thanks. Thanks.
Okay, our next speaker is Yi. She is a clinical pharmacist at UC Davis Health CF Center. She has practiced in the adult and pediatric CF clinics for 6 years. She received her Doctor of Pharmacy degree at the University of Wisconsin, completed her PGY1 at the San Francisco VA healthcare system, and her PGY2 at Sutter Health. She has spearheaded specialty pharmacy services in the pediatric and adult CF teams. So come on up.
Thank you very much. So today I will be speaking about probiotics and supplemental therapies in CF. This is my disclaimer, nothing to disclose. All right, so we will discuss the utilization of probiotics, the evidence for the utilization, as well as some other supplements in cystic fibrosis, as well as our clinic's experience specifically with beta-carotene. So first off, we'll talk about probiotics. So survey to the room, poll to the audience, how many people actually recommend probiotics for their patients? Okay. Minimally, so that's interesting to see. So what do we know so far about probiotics? We know that they have demonstrated potential in modulating gut microbiota, enhancing intestinal barrier function, and reducing inflammation. CF is also associated with an early state of chronic dysbiosis, which may contribute to many of the GI problems that our patients have. Chronic antibiotic use and poor quality diet further accentuates the dysbiosis, which includes reduced microbial diversity, overgrowth of pathogenic bacteria, as well as depletion of beneficial species. So there are a limited number of high-quality trials in probiotics in CF. However, I'm presenting 3 of them that I found among many, many out there in the literature. So the first one here is a double-blind randomized placebo-controlled trial, which investigated the effects of probiotics on how or whether they would improve pulmonary, GI, and growth symptoms in patients with CF. This was conducted in 110 children, age 6 to 12, all with pancreatic insufficiency. Using Lactobacillus reuteri, they found that both groups had gained weight over 12 weeks. However, there was no significant difference between the groups. The probiotic did not produce significant improvements in FEV1 BMI, frequency of exacerbation over 12 weeks. However, they did find improved reported quality of life in terms of reduced pain episodes at week 4. However, this trial has its limitations. Patients were only on probiotic for about 1 month, and the follow-up was conducted only at 3 months. The next trial here is a prospective double-blind crossover, which looked at the probiotic impact on calprotectin. So this was conducted in 30 patients at 2 geographically separate centers. And they found that there was a statistically significant improvement in GI health as measured by GI comfort per the Gastrointestinal Quality of Life Index test results, as well as a decrease in calprotectin level. And these were demonstrated after the 6 months of probiotic exposure. There was also a reduction in total bacterial density and an increase in microbial diversity. Again, this was a small size, and the effects measured were mostly on inflammatory markers rather than outcomes, large outcome endpoints. The third study looked at the impact of probiotics on pulmonary exacerbation. So this was another double-blind placebo-controlled study that evaluated the effect of probiotics on the rate of respiratory exacerbations and infections in both upper respiratory and GI tract. This was conducted in 61 patients with moderate to mild lung disease, and patients were on Lactobacillus reuteri for about 6 months. And they found that the number of pulmonary exacerbations were significantly reduced. The number of upper respiratory infections was also significantly reduced. The negative endpoints were that there were no difference in the mean number and duration of hospitalizations for pulmonary exacerbations and GI infections, and there were also no statistically significant difference in FEV1, fecal calprotectin, or cytokine measures. One of the limitations of the study includes the fact that patients were mostly of mild to moderate disease with FEV1 above 70%, and there was no improvement to the underlying inflammatory markers. So the guideline recommendation right now from the 2024 nutrition care guidelines for CF, they do not advise probiotic use with the purpose of improving clinical CF outcomes. And probiotics have no effect on pulmonary function, nutritional status, as well as quality of life. However, what do the trials suggest? So the quality of evidence remains low. Probiotics in CF may reduce markers of inflammation in the intestine and may modify gut microbiota composition. Overall, the patients tolerated probiotics pretty well in these trials. Probiotics may be considered an adjunctive therapy, especially for GI symptoms, but they are not yet the standard of care in CF. And there are no conclusive evidence for major clinical endpoints in CF. Next, we'll shift a little bit over to other types of supplements. There are very limited trials in this area as well. However, I'm presenting two that kind of stood out to me that were interesting. The first one, so very few high-quality randomized controlled trials of complementary or alternative supplements in CF, and none of them really showed any robust clinically meaningful benefit. So the first one that kind of stood out was a trial on antioxidants. So this was conducted at a multi-center randomized, and it was a double-blind placebo-controlled trial design. They evaluated the effects of antioxidant-enriched multivitamin on markers of inflammation and oxidative stress. 73 patients were included who are pancreatic insufficient, over the age of 10, and with varying lung function. The antioxidant-enriched multivitamin included vitamin A, C, E, selenium, as well as beta-carotene. So an antioxidant cocktail of those multivitamins as well as antioxidants. The outcome they found was that it did lower the risk of first pulmonary exacerbation requiring antibiotics in the treated group. The systemic antioxidant concentrations of beta-carotene, coenzyme Q10, gamma-tocopherol, which is vitamin E, lutein, they all significantly increased in the treated group. However, their primary endpoint, which was measuring the change in sputum myeloperoxidase concentration, was not significantly different. They also looked at this trial over a short duration of only 16 weeks. The primary outcome, again, was negative, and the lung function and growth endpoints were also negative. Another supplement, curcumin, this was a randomized double placebo trial which looked at nanocurcumin as an anti-inflammatory agent in 60 children over a 3-month period. And they specifically studied curcumin in nanomicellar form, which helped with the absorption of the curcumin. The anti-inflammatory biomarkers decreased significantly. Fecal calprotectin levels also decreased, and anti-inflammatory cytokine, IL-10, was increased. They found that the number of Pseudomonas aeruginosa colonies per nasal swab was also reduced, however, was not statistically significant. Weight gain was also improved, not significant, and there was no improvement in lung function. This was also over a short duration of time, and as you can see, many of the endpoints did not reach statistical significance. All right, so moving on to a supplement that we actually do put into our practice, which is beta-carotene. Just as a curiosity, does anyone else on their team recommend beta-carotene? Hey, very good. So there were 2 studies that demonstrated that beta-carotene supplementation provided substantial benefit for patients with CF by decreasing the duration of antibiotic therapy. It works as an antioxidant, which protects the lung tissue from oxygen-free radical-mediated damage and enhances immune function. So at UC Davis Health, there was an existing gap in knowledge of whether beta-carotene supplementation with CFTR modulators would result in any additional benefit. And so we wanted to evaluate whether beta-carotene supplementation decreased the duration of antibiotic use during pulmonary exacerbations. And so essentially we wanted to know if what we were doing was actually providing any benefit to our patients. This was at a single center retrospective cohort study which we conducted in our outpatient pulmonology clinic. It included adult patients who were diagnosed with CF, who were on CFTR modulator for at least 6 months prior to beta-carotene initiation, and patients have to have received beta-carotene supplementation for at least 6 months. Our primary endpoint was the number of days a patient required antibiotics for the treatment of pulmonary exacerbations per 1 day observed. And so this means that the clinical outcomes in terms of the results were multiplied by 365 days to project the days of antibiotic therapy over 1 year. Our secondary outcome included costs associated with ED visits, hospitalizations, the actual serum creatinine levels, and lung function measured by ppFEV1. So these were our patient characteristics. The mean age was 37, BMI 26, lung function mean was 65.6. Their beta-carotene level was low, around 23. And most of our patients who were on this were also started on Trikafta for at least 6 months. And we had a varying dosing for patients on this, including high then low dose, high dose, moderate dose, and low dose. So the primary outcome was the projected days of antibiotic therapy. And we did find that there was a significant decrease in the number of days of antibiotic therapy for our patients. So from 21 to 11 total days over the course of 1 year. The secondary outcome, cost of ED visits and hospitalization. So these were calculated very specific to our patients who were hospitalized or had ED visits at UC Davis, which is why we couldn't calculate it for all the patients that we studied. But we did see a decrease in terms of the cost at 1 month after. We also looked at the serum creatinine levels, and there was a statistically significant increase in the actual levels for these patients measured by the serum creatinine level. And within range for us, we consider is between 60 to 200. So the supplementation, as you can see, did not bring them within range, but it did increase their levels. And it could be the time frame of which we measured afterwards was not long enough. Another secondary outcome was ppFEV1. We did not see a significant difference between lung function before and after therapy. So some of the strengths includes that it was a novel design crossover study. Limitations include that it was retrospective, it was at a single center, and we were not able to fully assess patient adherence to supplementation, CFTR modulator, or other CF mediators. And the benefits may be from CFTR therapy still. So we found that the beta-carotene supplementation may lead to a decrease in the duration of antibiotic therapy, the cost of ED visits, and hospitalizations. However, additional studies do need to be conducted to explore the generalizability of these results to other institutions. So in conclusion, looking at probiotic supplements and beta-carotene, probiotics show potential in reducing the markers of intestinal inflammation and modifying the gut microbiome. Large-scale clinical trials are needed to establish standardized guidelines for probiotic use in cystic fibrosis. Vitamins, antioxidants, and other supplements do play a supportive role in enhancing overall health. However, effective and safety remains under investigation. Beta-carotene may serve as a useful adjunct in cystic fibrosis to combat chronic inflammation, as well as fat-soluble vitamin deficiency. The utilization for this in clinic should be guided by close clinical monitoring. All right, thank you very much for your attention.
Okay, I have a question for you. For curcumin, there are multiple case reports of supplement-induced liver injury. Which dosing did the study utilize, and would you change your recommendation given this information for liver toxicity?
Yeah, so we often, our practice across the board is not to recommend curcumin or generally any other supplements for patients, especially in patients with liver disease. And so that's something a critical factor to think about when your patients are asking to be on supplements or wanting to start on one, is looking at their liver function as well as what other drug interactions they may have with their current medication list.
You got all kinds coming in. Are there any adverse effects or other considerations with the beta carotene therapy?
Yeah, so we haven't seen, so it's fairly well tolerated among our patients. One patient population that we would be a little bit more careful with are patients who are current smokers or have a smoking history. However, most of our CF patients are not in that category. And so we have not seen any contraindication generally in the CF population for starting that.
Hi, I'm Julie from Penn. I just had a question about the probiotic portion. What's your current practice at your center? If is there a patient population where you're utilizing probiotics? If so, what type, dosing? Are your patients generally getting them from the enzyme programs or any other recommendations? Thanks.
Yeah, that's a great question. I wish I had a more definitive answer for you in terms of the dosing, the type. However, most of our patients purchase their probiotics from over the counter on their own, or we may provide it from us, but it is generally just cultural, is our primary brand that our specialty pharmacy provides. Patients typically start them on their own, and we just ensure that they're not immunocompromised or there are no other disease contraindications for starting it or continuing it.
Okay, let's see. So in the general population, some studies indicate that probiotic use directly after antibiotic use could be detrimental to the gut microbiome. Are there any studies for people with CF looking at this?
I did not specifically come across any studies looking at that, but in the studies I did see, they did mention that if patients were recently on antibiotics, they do separate it in time, I think by at least 4 hours, but there wasn't anything specifically pertaining to that I saw.
All right, thank you.
Thank you.
Okay, our next presenter is Kirby Smith. She's a patient medication liaison at the University of Missouri in Columbia. Since joining the specialty pharmacy in 2017, she has been assisting adult and pediatric patients with medication management, accessibility, and affordability. Advocating for patients while navigating insurance challenges has become a focus for her. So welcome, Kirby.
All right, thank you for that introduction, Adrian. Welcome to Leopard or Jaguar Spotting Alternative Fund Programs, the misidentified advocates hindering access to medications. Disclaimer, I have no disclosures. So for this agenda, we will talk about the 5 Ws of alternative fund programs, which I will refer to as AFPs, the impact of these AFPs, discuss differences that have allowed AFPs to affect patients through the differences of the Employee Retirement Income Security Act, ERISA, and the Affordable Care Act, ACA. And then steps that we can take to change AFP to mean advocating for our patients. So the 5 Ws, who, what, why. So who are AFPs? They are third-party, for-profit vendors that work with employer-sponsored, self-funded insurance plans to exclude specialty drug coverage or deny prior authorizations with the intent of shifting the cost from the payer to the patient, or other sources. There's a lot of common vendors out there. They're becoming harder and harder to spot because more and more of them are coming up to our patients. And so that's why leopard or jaguar, because you can't tell the difference. So what do? They convince plans to exclude some or all specialty drugs from their formulary in order to, quote unquote, save the money, while at the same time claiming to assist the patient in gaining access to medication through other sources, including patient assistance programs, samples, or even resourcing these drugs from other countries. And the problem is, bottom line, this rarely works as advertised. What are they not? And this is the big one that I like to make sure everybody's aware of. AFPs do not meet the criteria of being a covered entity under HIPAA. So they are not a benefit or plan, and they are not the payer. So in our practice, if I have somebody that I suspect that is an AFP trying to work on a case or a prior authorization for a patient, I simply exclaim to them that, sorry, I need a release of information before we can move forward with this, before I give them any patient information, just to make sure I'm protecting patients. And then the why. So why do plans use them if they don't work? The problem is that these programs claim to save the employers money by excluding these high-cost medications for the patients, right? When they do this employer seldom hears back from their plan members, their employees, that these AFPs are causing a problem or are intervening with their ability to gain access to these medications, because for them to do that, that would mean they would have to go and disclose their private health information to the employer. And in a lot of cases, they don't want to do that. They don't want to make themselves vulnerable in that way. So why do prescribers need to go through the AFP for authorizations? In many cases, these AFPs will misrepresent themselves in a way that it makes them seem like they are part of the plan. So for the technicians in the room, or anyone that does prior authorizations in the room, I'm sure you've seen the rejections come back that say, please contact insert name here, and gives the phone number for approval, right? And it looks like a legit insurance rejection. So you call them and then you're like, oh wait, this is an AFP, and it's diverting the plan, or diverting the authorization from the plan to them. And then there's other cases where they make them sound like they're the source of truth for anything related to coverage. So even if you go through all the steps, you get the double denial, you get the PAP, the patient assistance program denies it, it still comes back and they're like, no, we didn't do that, but you put in all the work and gotten all that information. So to try and get the insurance plan to cover it. But they won't take anything unless it comes from the AFP to give that override. So then why wouldn't patients with AFPs qualify for patient assistance programs? The problem is that the AFP tries to represent the patient as being uninsured. But when the patient assistance program goes and does their own internal benefit investigation, it reveals that the patient is in fact insured. And so then that disqualifies them and excludes them from being eligible because they got misinformation. And then many assistance programs are just now completely disqualifying patients that have an AFP. They're like, nope, you have this thing is associated with your plan that says that they're going to cover it for you, so that's who you have to deal with, so you don't qualify. So what's the impact? Creates gaps in therapy for patients that either can't get access, they can't get assistance, or they're going back and forth between insurance company and employer and the AFP and the doctor's office and all these different places trying to get access and trying to get an answer, and they just can't get it. So they go without medication. Or they try to pay out of pocket for it. We all know that that's a costly thing, and for our patients, adding that additional financial burden is oftentimes not possible. The programs that are available, like samples, patient assistance, medications, charitable assistance funds, they become overburdened or closed entirely, and patients that truly need it no longer able to access it. There are health and safety risks associated with medications that are being imported from other countries. Oftentimes those medications they may not be the same formula as what we have here in the States. They may not have the same active ingredients at all. Like, it could be completely different in another country, and it's not regulated by the FDA, so we don't have a way to monitor the true efficacy of that drug if it's coming from elsewhere. And then there's also compliance issues associated with ERISA, IRS, FDA, and all kinds of trade agreements and other laws that there are issues with, that create issues for these self-insured plans. So here's a little case study that shows you the impact of these AFPs. We had a 9-year-old female with cystic fibrosis, pancreatic insufficiency. Her parents had a self-funded plan through the employer. These benefits excluded all orphan drugs. Anything that's specifically for cystic fibrosis we know is being an orphan drug due to the minimal population for CF patients. Part of this was that problem one, patient had to use a specific pharmacy in order to get their specialty medications. The specialty pharmacy often misbilled or didn't bill secondary or tertiary plans, so they were trying to bill them hundreds to thousands of dollars for prescriptions that should have had zero copays. That problem was easily resolved by calling the pharmacy and explaining, hey, this person has a copay card, this person has a grant, this person has XYZ, they should not have a copay, they rebill it and it's taken care of. I think a lot of us experience that on a daily basis with some of these places. The bigger problem, though, was that because the orphan drugs were carved out, this included the patient's Dornase. We spent 9+ months working with the PBM, the plan, patient assistance program, employer, Compass, you name it, we were working with them to try and get patient access for this patient. But the AFP kept getting in the way. Finally got to the point where the patient was having the effects on the screen there. She was off the drug for 9 months, and despite using sodium chloride, she still had decline in lung function. She had marked deterioration of her lungs and increased pathogens and respiratory cultures. It took the patient getting that sick without the medication, on the verge of being admitted for an exacerbation, before the AFP would finally say, okay, give them the override. And patient has had medication since then, and trends are improving, so. But it took 9 months. So what is ERISA and ACA? And this is where it comes into how these plans are getting into the picture. So the Affordable Care Act does protect the 10 essential health benefits from being carved out of coverage, including prescription medications. But the problem is that self-funded plans are primarily governed by the Employee Retirement Income Security Act of 1974, known as ERISA. So the self-funded plans are generally exempt from many ACA reforms. So, example, they're not required to cover all the essential health benefits. They're able to establish which benefits and which types of medications they will cover. They do have to have it stated what's going to be excluded and what's going to be on the formulary and why. They can't just willy-nilly say, oh yeah, we're not going to cover that one. They have to give they have to put it into the plan. They still have to provide preventative care coverage for services without additional cost sharings. They still have to offer mental health care that's comparable coverage to medical and surgical benefits. And they still have to provide coverage for adult children dependents on their parents' health plans until the age of 26. Key points to focus on with ERISA and these self-funded plans include fiduciary duties, because despite carving out it, the employer still has fiduciary duty to the employers and to act in the best interest of the plan participants. So they think they're doing this in the plan because the AFPs are telling them that they're going to get access still. So they think that they're doing this, and they don't realize that they're not. They do have to have claims procedures in place, and or those are established by ERISA for how claims have to be processed. But ERISA generally preempts them from state laws, making them exempt from many state regulations. So if something new comes along that's a state regulation, if you have a self-funded plan, it may be exempt from said law. So how do we affect change? The biggest thing we can do is engage in public policy. There's not a one-size-fits-all for engaging in public policy. In fact, it's probably different in every state that you go to. And it can be intimidating. Think about going to speak with a legislator or anyone in power. It can be quite intimidating, especially when you're trying to make change for patients that you care deeply for. But the elected representatives at state and local levels are often more easily accessible and motivated to represent the needs of their constituents, because often the needs of the constituents are also their own needs. But the advocacy efforts have to be a broad focus. They can't just hone in on the one particular thing that you're looking at. You have to look at the whole picture. You have to look at opposing legislation. You have to look at it over a long course of time. It can't be a one and done. If you're in it until it's done. So each state manages advocacy differently, and volunteers that are working within these advocacy positions for legislators, they may not have any background in healthcare or advocacy, so you have to be able to talk to them and bring them in to the story. But every state does offer free online access about the status of legislation. The problem is that monitoring those can be hard if you don't know what the legislation is called, you don't know the legislation, the bill number, and those kinds of things. It can be very difficult to find those on these sites. These sites, though, are pretty easy to navigate and allow you to search by state, by bill number, find proposals, and as well as find contact information for your local legislators. So in summary, affordable alternate fund plans claim to assist patients with gaining access to medications by excluding self-funded insurance plans. These self-funded insurance plans are regulated by ERISA laws and do not have to follow the same provisions as fully funded plans under the Affordable Care Act. AFPs have a significant negative clinical impact on our patients, and we can engage in legislation as one way to impact change for accessibility for our patients. Thank you for your time. I'll take any questions.
Hi again. See, I would truly also advocate for at least one member of every CF care team. Doesn't matter who, just matters that someone understands the nitty gritty, like yourself, to participate on at least one board, advisory board in your state, whether it's on a Medicaid advisory board within your state, or even your state pharmacy societies or state pharmacy association boards, because that's where that one voice can come for the whole healthcare team to the legislatures, because that's where it matters. That's how things get changed. Yeah.
Thank you.
Thanks, Kirby, for that presentation. I just wanted to also mention, if for people that are interested in advocacy, I know the CF Foundation also has a pathway for that as well. So, I mean, if you get involved in the open forum sessions with the pharmacy group that are held once a month, I have reached out to Olivia with the CF Compass group, and she has connected me with some of the advocacy team members within the CF Foundation that have helped link to the particular bills that are going on in my state. So if someone else is interested in that in their state, that's another avenue as well. I just wanted to mention.
Thank you. And just a small little plug, I actually have an advocacy conference that I attend. It's the Healthcare Advocate Summit. It is the week of Labor Day every year. So next year we'll be in Las Vegas again. And if advocacy is something that's really important for you, it's an amazing, motivating conference to attend.
Kirby. Thanks. So I'm Justin from Primary Children's in Utah. Not really a question, but just kind of follow up to some of the stuff you're saying. We also have started to see these creep up a lot more recently, and we had a plan that decided to add this, and we had a parent reach out to us, and she's like, well, what the hell is this? And so we were like trying to explain to her and everything. Luckily for us, this was the one who is very active in advocacy and everything else. She went to the employer, kind of radicalized some of the other employees and went to her HR and actually got them to drop the AFP completely after that. So I do believe that legislation is definitely needed for these plans, but sometimes if just speaking to your patients and families, if they go to their HR and find other people that are having the same issues and taking that to HR, we have actually seen it now 2 or 3 times where their employers have dropped these plans.
Yeah, that's awesome. And that's why I mentioned, being able to go to the employer. Yes, it can be scary because it means disclosing that part of their health history or their family member's health history. But if you can get them together, one small voice can make a huge difference for everybody else, because everybody else might not be speaking up.
Okay, I have a question. How frequently are you coming across patients who have AFPs? How common are these?
We're a fairly small center. Between our adult and pediatrics, we have about 200 patients. And I think I have 3 patients that have an AFP affiliated with their insurance. A lot of ours are, we're a very low income area, so over 50% of my patients are Medicare, Medicaid, so.
Hi, Kirby. Really good discussion. So Greg from Nebraska Medicine. So we're lucky we have a really strong specialty pharmacy and we have our medication access coordinators team. So we're blessed to have some support. So I just, can't imagine if you are, hospital without a pharmacy, without a great, team, and it's relatively small. How do you, deal with those problems? Like you mentioned, you're relatively small center. So how do you use your resources?
So we do have an embedded specialty pharmacy at our location, and I'm from the pharmacy, but embedded in the CF clinic. So I see every single one of them that comes across, if it's a prior authorization or what have you. And the big thing I mentioned before was the making sure that you're getting consent from the family or the patient before discussing anything with the AFP, just to protect them and make sure that they're aware of what's going on. And I still execute everything in the order that I would if I was dealing with the plan, and I deal with the plan. So I still go to the plan for prior authorization. It's difficult because they will often kick back and say, oh, no, it's not covered. And then they don't have a denial letter of any sort for you because they don't actually do a denial. They don't actually do a prior authorization. And so trying to get that denial letter is probably the hardest thing, is to get that denial letter and get that second denial letter to be able to send those to the patient assistance program to go through those steps the correct way for the patients. It's the hardest part, is trying to get that denial letter and get it physically in writing, because they haven't actually denied it yet.
Yeah, just feel, especially in the busy months, beginning of the year, end of the year, it's just like we don't have enough manpower to get to literally every single patient had problem, right, with their insurance. It's so hard, it just delays everything. And now a lot of plans is like, oh, wait, response for 14 days, something like that. It's just crazy.
Yeah, I'm fortunate enough I have some backup that is able to help support me with keeping all my other patients on track, so that I can dive into the nitty gritty with cases like that come up and spend the needed time on that without letting the rest of my patients go without medication or the needs they need to have addressed as well.
Thank you.
I have one more question on here. Have you found a best practice workflow to follow when these issues arrive? For example, who do you call first?
So who do I call first? If I see that it's an AFP, and I'm pretty familiar with the one that we see all the time, I go directly to the plan and just execute it just like a normal prior authorization, like I was saying. I also notify the parent or family member or patient to say, hey, this is what's going on. This is going to take some time. It's going to be a fight. And depending on the medication, we can sometimes get samples. It happens a lot with pancreatic enzymes as well. So we're able to get some samples and help out there to bridge that gap while we're trying to fight through the process. But yeah, first call is to the plan and then to the patient.
Any other questions out there?
All right, I think we're done, everyone. We are a little early, so enjoy your break.